The ethical and professional obligation to address driving when delivering occupational therapy services. Learning objectives for this course are focused on acquiring and understanding information related to our ethical obligations as practitioners to evaluate and address potential deficits that impact safe performance in driving. Specifically, the learning objectives are: first, to recognize the professional and ethical obligation of practitioners to identify performance deficits that may affect safety in instrumental activities of daily living, or IADLs, specifically driving and community mobility. Second, to recognize the principles in the Occupational Therapy Code of Ethics and Ethics Standards 2010 that support the ethical responsibility of practitioners to identify and communicate the potential for harm to clients and relevant stakeholders. And third, to identify factors that indicate the probability of safety risks and both the related legal requirements to report the risks and the ethical obligations to warn when considering the occupation of driving. Just as the principles of the Occupational Therapy Code of Ethics and Ethics Standards, hereafter referred to as the Code and Ethics Standards, support the ethical obligation to identify safety risks and warn relevant parties, there is also a professional obligation related to identifying performance issues that may be related to safety in carrying out the individual's activities or occupations, including activities of daily living, ADLs, and instrumental activities of daily living, IADLs, such as driving and community mobility access. This obligation is supported by several official documents of AOTA. These documents are available on the AOTA website in the Practitioner/Official Documents section, accessible to members. For example, from the Standards of Practice, Standard 2, Screening, Evaluation, and Reevaluation, point number 8. An occupational therapy practitioner communicates screening, evaluation, and reevaluation results within the boundaries of client confidentiality and privacy regulations to the appropriate person, group, organization, or population, unquote. Standard 3, Intervention, point number 3. An occupational therapy practitioner collaborates with the client to develop and implement the intervention plan on the basis of the client's needs and priorities, safety issues, and relative benefits and risks of the interventions, unquote. In the Standards for Continuing Competence, Standard 5 Ethical Practice, it states, quote, the individual must demonstrate in practice the integrity to make and defend decisions based on ethical reasoning, unquote. And from the Code and Ethics Standards, language in principles to be discussed later in this PowerPoint related to client and public well-being, prevention of harm, and the need to communicate safety concerns accurately and timely while also being knowledgeable about legal obligations to report. The ethical obligation to provide occupational therapy services that address performance skill deficits and related client factors, which includes driving if it's an important IADL for that client. You wouldn't decide that a feeding evaluation was unnecessary because eating was unimportant. So if driving is a necessary and/or meaningful activity, why wouldn't you evaluate, intervene, or refer for the same? This obligation relates to Principle 1, Beneficence, and Principle 2, Non-Maleficence, of the Code and Ethics Standards, which are central to ethical conduct. They are about demonstrating a concern for the well-being and safety of our clients and protecting them from harm, and by extension, protecting the public as well. In addition, Principles 1D and 1F reinforce that we choose appropriate assessments to obtain the information we need and that they are current and evidence-based assessments whenever possible. While on the road and more specialized aspects of evaluating potential to drive may require an occupational therapist with advanced training, Even a generalist can obtain relevant data about potential driving performance and has an ethical and professional obligation to make those recommendations. Keep in mind that we are not benefiting clients if we don't share clinical findings and recommendations openly. In addition, this is applicable to practitioners across many settings. Intervention is not limited to older adults. It's across the lifespan and includes teenagers who may have a traumatic brain injury or attention deficit disorder, for example. In these cases, the relevant parties with whom to communicate information also include the family, school, teachers, or other professionals. Everyone on the team must be on the same page. Young to mid-age adults can also exhibit impairments which affect driving. Individuals who've had a stroke at a young age, or who may have Parkinson's disease or multiple sclerosis, which can cause cognitive changes and memory issues, or brain cancer, for example, can also demonstrate performance deficits in this area. Older adults, of course, can have musculoskeletal issues, perception, cognition, and/or memory deficits. So you can't assume that driving should not be addressed except in older adults who've had a sudden medical incident. The same moral obligation applies. We have dual obligations to clients for their benefit and to society for the greater good. Practitioners should evaluate and provide driving-related services at their level of competence, which could be general evaluation in the clinic, specialized equipment evaluation in the clinic, and/or on the road. Principle 1E of the Code and Ethics Standards supports this, stating, quote, "Occupational therapy personnel shall provide occupational therapy services that are within each practitioner's level of competence and scope of practice. Qualifications are based on education, experience, and language in the law or licensure act," unquote. This relates back to Principle 1, beneficence, or doing good for the client, as previously discussed on Slide 4. According to Principle 1I, practitioners are also obligated to, quote, "refer to other healthcare specialists based solely on the needs of the client," unquote. And we should advocate for clients to receive necessary services, which is reinforced in Principle 4E, social justice. But even generalist occupational therapists are qualified to provide a basic level of evaluation that addresses skills relevant to driving and to make recommendations. In addition, the language in state practice acts, although quite general, legally defines the occupational therapy scope of practice, and based on occupational therapy educational curricula, includes the components of evaluation and intervention which are relevant for ADLs and IADLs, including driving. For clients with more complex needs, we may need to refer to someone with more advanced training to meet the client's needs from a competency and ethical perspective. One thing that's important is the need to close the gap between service providers. We can't just give clients a list of driving schools or therapists who claim to specialize in driving evaluation without actually knowing if they're qualified and if it's an appropriate referral. We have an ethical obligation to get some information about potential resources so that we can make appropriate referrals and ensure that clients' needs are met. Despite their qualifications, as noted on this slide, in practice, occupational therapists often seem reluctant to exercise their professional judgment and commit to a definitive recommendation, particularly related to driving, whether it is referral for more specific testing or actually to cease driving. Many do not appear comfortable with a situation that may have some ambiguity, or they are not confident about their own knowledge and skills to make a judgment about risk that may have serious consequences for their client, perhaps hoping that someone else will do it. But we are in an often unique position of having the critical and comprehensive data about most of the factors that influence safe driving, and as professionals, we owe it to the team and the client to contribute that information. Occupational therapists routinely assess safety through evaluation and intervention, observation, and testing. They should select assessment tools that, based on the client's medical and social history, will provide meaningful information and identify performance deficits to focus the intervention plan. Along with clinical, professional, and ethical reasoning, This supports the therapist's ability to make accurate judgments about the type and extent of any impairment that may affect the client's safety in daily activities. Driving is an activity that may be relevant to many clients and therefore should be considered in reviewing all data and addressed in developing a plan of care, as well as kept in mind for future referral, rehabilitation, or training needs. Even before beginning an evaluation, the client's diagnosis may raise a red flag about potential safety concerns related to ADLs and IADLs, including the future ability to resume safe driving. Certainly, dementia, depending on the type and stage, must be seriously considered. In addition, neurological diagnoses such as a stroke may result in visual perceptual deficits that affect judgment of distance, objects in space, visual field, etc. These can all have an impact on the ability to safely move about the kitchen and prepare a meal, get in and out of the tub and bathe, and navigate a car on the road, to name just a few examples. With evaluation data available, performance abilities and deficits can be identified more specifically. This will form the basis for collaborative goals and a plan for intervention. But depending on the evaluation results, it is possible that some client goals will be unrealistic. For example, severe visual impairment, which may by state law preclude driving, or cognitive deficits that do not support the judgment required to operate a vehicle. Some specific factors that may affect safety and that should be addressed in therapist recommendations or warnings can include orthopedic, neurological, and visual perceptual deficits. Clients who have limited active range of motion in their upper body not only are likely to have difficulty reaching for overhead items, performing some ADLs, but also may not be able to turn their head to safely look over their shoulder when backing into a parking spot or pulling out onto the road. Vertebral compression or short stature can affect the ability to sit high enough in the driver's seat to properly see the road and full environment, as well as affect the ability to control the gas and brake pedals. In the case of the latter, a modification to the car may fix the safety issue, as may a cushion on the car seat to elevate the driver. But without these devices, safety can be compromised. Wearing a cast or splint may compromise the ability to grip the car wheel or react quickly to avoid a collision, just as it can affect safety in carrying hot pots in the kitchen. Individuals who've had a stroke may have a visual field deficit on one side, which makes driving unsafe. Head trauma may also cause visual or neurological deficits that affect safe performance of ADLs and IADLs. In addition, environmental scanning requires the driver to see and identify important signs and objects from the very busy background of the typical road. Obviously, depending on the degree of visual impairment, modifications such as daytime driving only or sensation may need to be considered. Impaired sensation or proprioception, which may result from conditions like diabetes, can affect safety and result in injury. For example, if an extremity is in contact with something hot, such as a hot pot or stove burner, yet does not register the danger or sensation and move away quickly. It can also result in the inability to gauge appropriate foot pressure on the gas or brake pedal, which is a safety concern in driving. Cognitive deficits can cut across a wide spectrum, but regardless of origin are likely to have an impact on safe performance, especially related to driving. This requires warning to both the client and his or her family or caregiver. Cognitive status can be fluctuating, such as with multiple sclerosis or some types of dementia. It can decline gradually, as with Alzheimer's disease, or it can be consistent but diminished, as for example, the high-functioning executive function issues that are common with traumatic brain injury or decreased attention to task and poor judgment, typical of adolescents diagnosed with ADHD. Comprehensive or focused occupational therapy evaluation to identify performance skills and client factors that affect safety may include both standardized and non-standardized assessments, occupation-based assessment, and observation. Safety issues that are relevant to ADLs and IADLs, including work or leisure activities, can be addressed in the intervention plan and result in appropriate recommendations and warning if needed. This is particularly relevant to the IADL of driving, as the safety of not only the client but also the public can be compromised. In addition to objective assessment and observation, a key element is the occupational profile, which identifies from the client's perspective activities that are necessary or meaningful. Considering the client's clinical status as well as his or her occupational profile will determine goals for intervention that are realistic and can be the foundation for a discussion about safety in performing these activities or alternative options to meet these needs if feasible. In some cases, for example, driving for an adolescent seeking his or her first license, but who has consistently demonstrated impulsiveness and inconsistent ability to attend to tasks, referral for more specialized evaluation to make a determination about performance and safety may be required. These performance safety concerns are similar to clients who live alone and need to prepare meals but have poor memory and balance, do not remember safety precautions when transferring on or off the toilet, in or out of the tub, or when cooking and needing to turn the oven or burners off. Likewise, clients returning to work may need to remember and follow safety procedures related to an assembly line or equipment operation in the workplace. These types of safety concerns are typical of those where the occupational therapist has the data and the professional as well as ethical obligation to warn clients to ensure well-being and prevent harm. A critical part of the occupational therapy evaluation and treatment planning process is communicating the results to the client and, where appropriate, the family, significant others, and/or caregivers. Just as we would warn clients about potential safety hazards and risks in performing ADL tasks in the bathroom or other potentially dangerous parts of the home, we have an equal responsibility to explain evaluation results which may have a negative impact on their ability to drive or use community mobility safely. Transparency in conveying evaluation data and interpreting its impact is an ethical obligation. It is also an ethical obligation to ensure that it is understood and that the opportunity for full discussion, questions, and clarification is available so clients know what the information means and how it will affect their lives. This is particularly relevant to how they will perform their daily activities and making any changes that are needed to ensure continued participation in a safe manner. From an ethical perspective, this demonstrates respect for the client and supports their right to make decisions based on their values, preferences, and full disclosure of information to understand the benefits and risks of the decisions they make. In communicating evaluation results and their implications for daily activities, it is important to use objective data to support concerns, but also to discuss strategies to maintain the ability to perform these activities, perhaps in a different but safe manner. Drastic recommendations, such as a condition which would necessitate driving cessation or a marked change in driving and mobility routines, will require time to digest and planning to explore, accept, and incorporate new routines. It is important to support clients in this process and help them understand that these decisions do not need to be made on the spot. At the same time, from an ethical perspective of benefiting our clients and preventing harm, the rationale for the recommendations and need for compliance to promote safety, both for the client and for the public, must be strongly reinforced. Occupational therapy practitioners also have a professional and ethical obligation to document their findings accurately and timely. It is critical to document evaluation results, both strengths and impairments, and link them to their impact on safe performance of occupation-based activities. Discussions, recommendations, and warning to clients and families about safety concerns and parameters for performance to enhance safety should also be explicitly documented and shared with team members on a need-to-know basis. so everyone involved in caring for the client is aware of their status and can reinforce the importance of compliance. Any referrals to specialists to obtain additional information needed for accurate recommendations should also be documented. This might be appropriate for an on-the-road evaluation or an enhanced in-clinic evaluation for factors related to driving. In the case of driving, occupational therapists should document objective data to meet state law and other applicable standards. This is important to defend and support their safety recommendations, which may include restrictions in activities, including cessation or limitation of driving or use of alternate community mobility. Ultimately, the intervention plan and goals result from considering objective and subjective data from the evaluation, client input, and the application of professional and ethical reasoning to interpret the information. Recommendations and warning, if appropriate, should be the outcome if safety concerns in any performance areas are evident and are supported by data. This is in line with Principles 1 and 2 of the Code and Ethics Standards, which reinforce our obligation to, quote, demonstrate a concern for the well-being and safety of the recipients of services, unquote, and the obligation to, quote, not impose risks of harm even if the potential risk is without malicious or harmful intent, unquote. Occupational therapists are qualified to make these recommendations based on general occupational therapy evaluations, even if they also identify a need for further, more specialized assessment related to potential safe driving ability. Although occupational therapy practitioners need to be alert to and communicate the importance of safety concerns related to any activities in which their clients engage or wish to engage, the IADL of driving deserves extra consideration. Driving is a good illustration of the importance of assessing safety and warning where risk may be a predictable or probable outcome. In addition, there is a tremendous age span of people who drive. Virtually all individuals drive for a significant portion of their lives. Therefore, this is not only a potentially high-risk activity, but also a high-volume one. The demographics of significant growth in the older population due to baby boomers turning 65 also contributes to the unusually high volume of individuals who are more active and want to continue to pursue their work and life activities with the independence that the ability to drive conveys. This reinforces the importance and obligation of occupational therapists to consistently ask clients questions about whether driving is a desired and important occupation and the role it plays in their lives. Ethical reasoning is one of 5 standards for continuing competence, which also include knowledge, critical reasoning, interpersonal skills, and performance skills. It's clearly an important component in the overall decision-making process related to driving. One of the most critical ethical issues is balancing the needs and desires of the client, or autonomy, the right to make their own decisions, with the needs and desires of the public. Who should prevail, and what factors should be considered in making that decision? Is the greater good, for example the public, more compelling than autonomy of the individual? Who has the right to make those decisions, and what are the criteria? Obviously, these are complex issues, and the best, most appropriate decision can also depend on context and the individuals involved. Overall, safety has to be a primary concern, yet adds to the complexity. Whose safety do we consider? The client's safety, since we have an ethical obligation to prevent foreseeable harm, but yet have an equally compelling but broader ethical obligation to not knowingly put the larger population or public in harm's way. Our society supports individual values, but at what point should there be limitations on the expression of those values and desires to create benefit for the larger group? Occupational therapy practitioners can be faced with sorting out these ethical dilemmas, and in fact may have a professional responsibility to do so, if they have first-hand knowledge that is germane to the situation. Practitioners can acknowledge that these are complex issues and seek help to resolve them, but should not remain silent if they have the knowledge and skills to make a reasonable clinical judgment. This is no different from recommendations we make around safety and ability related to other ADL and IADL tasks. Hoping that someone else will evaluate, report, or take action is not consistent with our ethical and professional responsibilities. Because these can be complex dilemmas with multiple possible resolutions, a framework for ethical decision-making can provide a systematic method for evaluating these questions and can assist in making the best decision in the circumstances. Many frameworks exist. One of these will be discussed later in this presentation. I encourage you to utilize this process whenever you encounter ethical dilemmas in the workplace and even beyond. There is broad applicability of virtually every ethical principle in the Code and Ethics Standards to situations where safety is at risk. Some of the most relevant concepts and language include Principle 1, Beneficence. This is the basic goal and outcome of all occupational therapy services. Doing good, benefiting the client. Providing services that in your professional judgment have a reasonable, objective likelihood of improving the client's skills and abilities. This means ensuring that they can perform necessary and/or meaningful activities safely or are warned about limitations for their own benefit. Principle 2, Non-Maleficence. Also, includes an obligation to not impose risks of harm even if the potential risk is without malicious or harmful intent, unquote, as stated in Principle 2 of the Code. This concept is further elaborated on by Beauchamp and Childress in the classic text Principles of Biomedical Ethics, published in 2009, and is often examined under the context of due care. If the standard of due care outweighs the benefit of treatment, then refraining from treatment provision would be ethically indicated. This is applicable in driving evaluation, for example, if considering an on-road evaluation when even a clinic-based occupational therapist who does not have any specific driving training may already have the clinical information he or she needs to make a recommendation about whether driving is safe, and if so, with what parameters, and they have an ethical obligation to do so. For example, with the diagnosis of epilepsy, an occupational therapist doesn't need to witness a seizure to confirm the recommendation. Further language under this principle stresses the importance of the practitioner maintaining objectivity, professional boundaries, and analyzing directives to ensure that the well-being of our clients is protected, which reflects concepts in the corollary Principle 1 of the Code and Ethics Standards, which is beneficence or doing good. Principle 3, Autonomy, is about the individual as their own agent and acknowledgement of, quote, a person's right to hold views, to make choices, and to take actions based on personal values and beliefs, unquote. Again, as stated in Beauchamp and Childress, text from 2009. We also need to consider the concept of substituted judgment if mental competence is in question. Is there a legal healthcare proxy or guardianship? Transparency and full information are required to allow the client or perhaps the family to make an informed and collaborative decision. But we can't put responsibility on the client or family if we are not transparent in communicating concerns, risks, and options to address them. It is critical that the patient and family fully understand safety recommendations, whether they relate to transfers in the bathroom or cessation or limitation on driving, along with the rationale for those recommendations. We also need to facilitate open dialogue with clients and families and ensure that they comprehend the information we are conveying. Principle 4A states, quote, occupational therapy personnel shall uphold the profession's altruistic responsibilities to help ensure the common good, unquote. In the case of driving, are we doing that by knowingly allowing individuals who may have an impairment to jeopardize their own and society's safety? This is a relevant question for those allowed on the road despite solid evidence or concerns about documented deficits. This language also reminds us of the challenge of balancing individual rights, autonomy, and preferences when they may conflict with the common good. Principle 5, Procedural Justice, states, quote, "Occupational therapy shall comply with institutional rules, local, state, federal, and international laws and association documents applicable to the profession of occupational therapy," unquote. While there may be situations where what is legal and ethical are different, occupational therapy practitioners have a responsibility to be aware of any laws, regulations, or requirements that are applicable to reporting safety concerns, specifically in the area of driving ability, as they can guide decision-making and can supersede ethical preferences. If you recommend driving cessation and the client or family refuses, what are the ethical and legal obligations? This can be about warning versus failure to warn, and is a good illustration of the differences between legal and ethical. Laws may require reporting or warning, but if they're silent, what is the ethical obligation to warn and the implications of failing to warn when the individual poses a danger to self and/or others? Principle 6, Veracity, in this context, refers to accurate and timely reporting of all information related to professional activities in accordance with applicable regulations. Specifically, Principles 6b, 6c, and 6e are relevant. Principle 6b. Language in this principle states that, quote, "Occupational therapy personnel shall refrain from using or participating in the use of any form of communication that contains false, fraudulent, deceptive, misleading, or unfair statements or claims," unquote. Principle 6c states, quote, "Occupational therapy personnel shall record and report in an accurate and timely manner and in accordance with applicable regulations all information related to professional activities," unquote. Since the medical record is a legal document, misinformation can have serious consequences. Failing to include a cessation of or limitations on driving as a recommendation if the evaluation data warrants, and again if driving is an IADL for that individual, is misleading and inaccurate documentation. Principle 6e is also relevant. It states that practitioners also must accept responsibility for actions that reduce public trust in occupational therapy. Failing to use professional judgment and act accordingly may not reflect well on occupational therapy if deficits were evident, yet the client was not advised of safety concerns, counseled about alternate mobility options, and/or continued to drive freely. Also consider Principle 7h, which asks us to be, quote, "diligent stewards of human, financial, and material resources of the employer," unquote. Depending on the situation, is an evaluation, particularly an on-the-road test, a waste of time, money, and resources? If enough data is available to predict the outcome and future recommendations, and given the limitations in all of our healthcare resources, so we have the ability and obligation, based on our knowledge and skills, to make objective, accurate determinations of potential risk and benefit. And risks should lead to warning, the scope of which can be determined by the degree of risk and the context. For some, it may require modifying their driving habits, for example, distance or time of day, etc. For others, total cessation may be the most appropriate recommendation, followed by a discussion about transportation or mobility alternatives. Clients deserve to have these issues addressed in a straightforward way with options that are realistic and available, so they remain as independent as possible. Recognizing potential ethical issues is more common than actually meeting the challenge of having the moral courage to act to protect both client and society. Moral courage relates directly to failure to warn, because without action, change does not occur. So who does "don't ask, don't tell" protect? No one. Both client and public, as well as the therapist, are potentially at risk. These can be consequences of failure to warn. In analyzing ethical dilemmas, one of the last but most important steps is deciding on an action and doing it. The doing part is the critical piece, as without action, again, change will not occur. Legal and ethical can be the same, but they aren't always. Although something can be legal, it may not be ethical, and that's why we need to understand what our ethics standards say and how to apply them to practice. Even if we're not legally required to report a potentially impaired driver, what steps should we take ethically if we have professional, objective information that continued driving may cause harm to that individual or others? We should be telling clients about options and capitalizing on the therapeutic relationship and trust that often develops between client and therapist to introduce effective recommendations even when they may be difficult. Just as we may separate legal and ethical, what about the influence of reimbursement on clinical decision-making, as is common in many settings today? Is the fact that driving may not be covered by Medicare a defendable reason to withhold the information that a client needs a driving evaluation or that their driving ability may be in question? The answer is no. Remember, Principle 1, beneficence, is central to ethical conduct. It says, quote, "Occupational therapy personnel shall demonstrate a concern for the well-being and safety of the recipients of their services," unquote. The corollary to Principle 1 is Principle 2, which mandates that we protect clients from harm and, by extension, protect the public as well. We are not benefiting clients if we don't share clinical findings and recommendations openly. Getting issues of impaired driving or the inability to drive into the open demonstrates transparency and allows the client, the therapist, and the family to move on to productive, realistic problem solving with strategies for community mobility that will be feasible and benefit the client as well as preventing harm. Where state law does not mandate reporting, practitioners may face a conundrum. Balancing an ethical obligation to intervene to prevent imminent danger to the public from an impaired driver weighed against the need to uphold patient confidentiality. Reporting, or at least documenting and sharing recommendations with the client and other key individuals, is a professional obligation for those in the role of guardians of the public's safety. Since prevention of harm is a key principle in the Code and Ethics Standards, this is a reasonable extrapolation. Therefore, although occupational therapists do not have the authority to remove a license, they do have the ethical responsibility to share clinical findings that relate to impairment and safety, both for the client and the larger public. Further, case law from North Carolina courts, Curry v. United States, 1986, expanded the impact of the landmark Tarasoff case, which will be discussed in the next slide, by stating that, quote, "Citizens outside of the readily identifiable sphere, but still within the foreseeable zone of danger, are potential victims a therapist should consider if he has a duty to them and a means of adequately protecting them," unquote. This is from an article by Love et al., information for which is on the reference slide at the end of this presentation. Personal autonomy, the freedom and right to control oneself and make choices and maintain privacy, does not, quote, "overrule the rights of other persons," unquote. Also from the article by Love et al. Relevant information on these points can be found, as mentioned, on the reference slide at the end of this presentation. Occupational therapy practitioners consider the impact of foreseeable harm in self-care and other IADLs, but it's obviously greater in the arena of driving. Duty to warn was first established in Tarasoff v. Regents of the University of California in 1976. In October 1969, Tatiana Tarasoff was murdered by her former boyfriend, who was being treated by a psychologist at Cal Memorial Hospital at the University of California at Berkeley. Several months prior to the murder, the boyfriend, Mr. Podar, told his psychologist that he planned to kill his former girlfriend, whose identity was deduced by the therapist. a threat which the psychologist found to be substantiated. 2 colleagues at the hospital also examined Potter and agreed with the likelihood that the threat was real. The psychologists initiated commitment procedures, but were overruled by the chief of psychiatry, who instructed them to release Mr. Potter. The treating psychologist did report to the campus police, who detained the patient and questioned him, but determined that he was not a risk and released him with an agreement to stay away from his former girlfriend. Mr. Potter subsequently killed his former girlfriend, Ms. Tarasoff, whose parents then sued the university regents, physicians, and campus police for failing to warn them about the danger their daughter faced. The main precedent in Tarasoff and other court cases related to confidentiality is the lifting of privacy for probable cause, based on concern for public safety and the concept of a duty to warn. Yet reporting by physicians is still voluntary in many states, probably to give weight to privacy and the sanctity of the physician-patient relationship. Although this case and significant case law that followed most often specifies mental health practitioners, the principles are ethically applicable to other situations and professionals in a position to predict that harm may occur. Occupational therapy practitioners may be familiar with state laws requiring that they report child or elder abuse. Some states' laws may also mandate reporting medical impairments that could affect the ability to drive safely. Occupational therapists should be familiar with relevant laws in their state and whether they have the ability or requirement to directly report, or whether recommendations must go through a physician. Further, case law expanding on Tarasoff related to mental health practitioner defines potential victims of a cognitively impaired driver to be anyone, quote, having the potential to contact the car in a violent manner resulting from a driving error by the impaired driver, unquote. This quote is from the article by Love et al., 2008. As a result, the legal duty invoked on the practitioner is to promote safety of both the community and the client whenever possible. Occupational therapy practitioners may be under the same legal obligation, but even if they are not, the concepts deriving from this case law reinforces an ethical obligation to consider safety from a broad perspective when warning may be required. Some state laws, for example in Massachusetts, do grant immunity to providers who report impairments that are likely to negatively affect the ability to drive safely if the provider reports in good faith based on objective data. The ability to report if harm is a concern reinforces the importance of even generalist occupational therapists including driving in their initial evaluation as a potential IADL to be addressed, and being alert to assessment data that may correlate with decreased safety and increased risk. What is the least invasive method of addressing the situation? As a first step, and always one of critical importance, document your actions in the medical record. Documentation should not only reflect data, but also the conversation that should happen between the therapist and the patient, and family, caregiver, or other significant individuals if appropriate. Second, report to the physician, making the link between the occupational therapy data that was obtained and the concern for driving safety. Include a description of what was shared with the patient as well as their response. Was the patient receptive to the safety recommendations? Did they understand concern not only for them but also for public safety? Or were they resistant to any recommendations that entailed a limitation to the ability to drive as they wish? Sharing findings and recommendations directly with the patient demonstrates respect for their right to autonomy and making decisions based on information. See the prior discussion about the ethical principle of autonomy for more content related to this topic. Reporting to the physician, but not sharing data and recommendations with the patient, does not respect the patient's right to autonomy in making healthcare decisions. However, a situation may occur where the physician requests that the occupational therapist not discuss results with the patient. The physician, as manager of the patient's care, may choose this responsibility. Ethically, the occupational therapy practitioner should respect this, but discuss with the physician and document that the plan is for the physician to convey the recommendations related to driving to the patient. In addition, to clarify, the occupational therapy report at the generalist level may flag risk and connect this risk. Finally, keep in mind that professional liability is different than a professional obligation. Practitioners should be protected if they use an avenue to report a valid safety issue in good faith. Although it's unlikely that cognitively impaired individuals will make verbal statements that threaten violence, diminished cognitive ability to drive has the potential for equally destructive risk of violence and loss of life. Continuing to drive when warned of impairment may be a form of nonverbal communication about intent to harm from a client, motivated by the overriding desire for independence or to meet community mobility needs. So therapists must address alternative strategies to fulfill those goals. This type of communication from a patient can be considered to be outside of the privileged environment of a session with a health professional, further supporting the obligation to warn. With diminished cognition, competency can vary in intensity and functional impairment, with both good and bad days, so it may be a challenge to make appropriate recommendations with an evolving cognitive status. While there is an equal ethical obligation to warn about safety concerns due to impaired cognition related to general ADLs and IADLs, in the case of driving, it's even more critical, as there is potential for harm not only to clients themselves but to others who are potential innocent victims. The ethical practitioner considers the greatest good for the greatest number of people and tries to balance potential risk to and by the impaired driver with the realistic concerns of society, while maintaining a commitment to the health and privacy of the patient. Principle 1M of the Code and Ethics Standards states that occupational therapy personnel shall, quote, report to appropriate authorities any acts in practice, education, and research that appear unethical or illegal, unquote. This requires that occupational therapy practitioners take responsibility to know the laws in their state with regard to reporting. However, many practitioners are concerned about breaching confidentiality if they report, because protecting client confidentiality is also a core ethical principle, one that clients can expect in the therapeutic relationship. But under what circumstances can the confidentiality privacy mandate be waived if the client has the potential to inflict harm? Here are some things to consider related to disclosure. Principle 3G of the Code states that while we must, quote, ensure that confidentiality and the right to privacy are respected and maintained regarding all information obtained about recipients of service, the only exceptions are when a practitioner or staff member believes that an individual is in serious, foreseeable, or imminent harm. Laws and regulations may require disclosure to appropriate authorities without consent, unquote. In Massachusetts, a law recently passed which names occupational therapists as able to report individuals they believe to be impaired based on medical and therapy data, and they have immunity if the reporting is in good faith. On the other hand, Principle 4 of the Code and Ethics Standards encourages advocacy to meet client needs. Rural areas may not have public transportation, and even cities may have limited accessibility for public transport depending on the client's deficits. To fulfill that potentially challenging obligation, occupational therapy practitioners must consider mobility and transportation or alternative methods to meet the client's needs to participate in community leisure activities and IADLs such as marketing, errands, and work, volunteer or paid, when a safe return to driving is not a viable option. In addition to legal mandates, again, consider the multiple potential significant risks of not warning and/or not reporting. As we have been discussing, ethical issues related to identifying and potentially reporting impaired clients who may pose a safety risk to themselves and others can be complex. A framework for ethical decision-making can assist in clarifying, analyzing, and hopefully resolving them in a satisfactory manner. A number of models for making ethical decisions exist, and most have certain key elements in common. The one offered here can be used to assist in thinking through the cases that follow in this course. A critical first step in resolving an ethical issue is identifying the nature of the perceived problem. Is it ethical distress, where you know what to do but there's an obstacle or barrier preventing you from acting? Or is it an ethical dilemma? In this case, there are two morally acceptable actions, but if you do one, you can't do the other. The situation could also involve two undesirable choices. Next, what is the specific problem? This is similar to clinical reasoning, where we name and frame the problem and sort out the issues. Who are the players? Not just those immediately involved, but others who may be influenced by the situation or any decision that is made. What information is known and what additional information is needed to thoroughly evaluate the situation and formulate options? What resources are available to assist? Then consider what are the options and likely consequences of each option. Prioritizing values is important. Ask yourself whether you're willing to prioritize moral values in spite of potential negative personal repercussions in order to act on what you believe is the best decision. Keep in mind that, quote, good intentions do not always bring about good deeds, unquote. Then decide on an action, take it, and be able to defend it. It is important to allow time to reflect. Was the outcome what I expected? If not, why not? Would I do the same thing if I had the same situation next time? A framework for ethical decision-making assists practitioners with a systematic method of identifying potential ethical problems and resolving them, hopefully with an outcome the practitioner can defend, although it may not be perfect. Because every situation is different, the intent is to provide a reasoning process that is broadly applicable when approaching these challenging situations. Now you will have an opportunity to use what you've learned about ethical issues related to driving in several case studies. In the first case, an 82-year-old woman is the primary driver for her husband since his stroke 3 years earlier. She fell at home 2 months ago, sustaining a fractured right hip and mild concussion. She has been in a subacute rehabilitation facility and is preparing to go home. Evaluation results indicate mild memory impairment. The Trails A is within functional limits, but Trails B required 120 seconds with 2 errors. Her right hip remains painful, and she uses a quad cane for ambulation. She demonstrates some confusion around recalling how frequently she's able to take her pain medication and frequently requests another dose earlier than prescribed. The nursing staff has had to remind her on 3 separate occasions about the duration of time before she can take her next dose. During self-care, she demonstrates slow movement when putting her right leg into her pants due to pain and swelling. Their daughter has been caring for her father until Mom can resume her caregiver role. Mom insists she's fine to drive, and the daughter eagerly agrees. Money is very tight, and they promise to contact occupational therapy if driving does not go well. This subacute facility does not have an on-site driving program, so a referral to a community program is required. The easiest solution is to not get involved. It's a family decision anyway, isn't it? And we can trust that the daughter has her mom's best interest at heart, right? This patient has potential safety issues that can relate to both physical and cognitive status. Therefore, we have an ethical obligation to get involved for all the reasons on this slide. A framework for ethical decision-making, as previously discussed, can assist in analyzing and resolving these types of potential ethical dilemmas. The actions of the individual practitioner involves consideration of the following questions, which reflect elements of such an analytical framework. The occupational therapist has the ethical obligation to ask themselves these types of questions to ensure that they have enough information to make sound recommendations and defend them. They have an ethical obligation to consider all aspects of a situation, from a clinical perspective so that the intervention plan is comprehensive and addresses any concerns related to driving from a patient and public safety perspective. So what are the ethical issues? What do we need to think about in this case? What information might we need? First, the right leg is still impaired with mobility and pain issues. The right leg is used to operate the gas and brake pedals, so is this individual safe to drive? What about the memory impairment? Does this warrant more specific further testing to get objective data about the extent and type of impairment? Is the concussion resolving? Do we need baseline information and a retest in a few weeks or months? Aside from memory impairment, what is the impact of medication the patient is taking on cognitive skills? What did the occupational therapist recommend related to driving? We would want to know that. What communication did the occupational therapist have with the patient, family, and other team members about concerns related to safety, and did she warn them about potential safety issues for both the patient and others if she drives? Did the occupational therapist have readily available resources to address driving community mobility issues while the mother is recuperating, and for driving rehabilitation if she needs further help to resume that IADL? Did the occupational therapist stress the potential seriousness of driving while impaired and bring the physician and relevant others in to support her recommendations? Conveying accurate information is an obligation as stated in Principle 6, Veracity. After discharge, who will judge whether the driving is going well? What is the responsibility of the daughter to fully understand the impact of her mother's condition and how it may affect the safety not only of her mother and the public, but also her father, who is a patient with his own medical conditions? The father is also a passenger, presumably in the car, so having his own medical conditions and being a passenger can also be affected if the mother is not a safe driver. Does the daughter understand the potential liability issues and take them seriously versus looking at the convenience of having things back the way they were without her involvement? Since money is an issue, will the daughter and parents try to make it work, overriding objective information that might suggest a problem requiring further evaluation? Ethical decisions can sometimes involve prioritizing other values or actions over personal wishes. For example, the daughter's wish to be done with driving her dad around. That's why they can be so challenging. If you were confronted with a case like this, what would you do, and why? In this second case, 16-year-old Kaylee cannot wait to drive. She has ADHD. Her school IEP includes extended time for test taking and the option for a quiet room. She's been held back one grade level. She struggles to keep a C- average. She's easily frustrated and has few friends. She hopes that offering rides might be a way to make friends. Her older brother just moved back home after being away at college for 5 years. He plans to teach her to drive. He is 22 years old, they are very close, and Kaylee looks forward to spending this driving time with her brother. The occupational therapist does not think she's ready for driving, not yet. She would like to suggest they wait at least until next year, but wonders if it's within her role to make this suggestion. Again, this is a case that relates to safety and our ethical obligation to warn when the client, in this case the student, may be in potential or foreseeable danger. So what do we need to think about in this case from an ethical perspective? Kaylee has received occupational therapy and other services in school to address and accommodate her ADHD, so the team presumably has valuable information about performance skills that would also be relevant for driving. Her ADHD manifests itself in decreased attention to task and impulsive behavior, all potential hazards when driving. Her motivation for driving is not grounded in reality. For example, to make more friends. So insight and realistic problem solving is likely to be impaired. In addition, if she's driving friends around and we know she's already distractible, that will cause more distraction, and of course, what about the potential to cause harm to other kids, other drivers, and pedestrians if Kaylee is not a safe driver? Has there been a team meeting about this? What information has been shared or not, and what discussions did or did not take place? What is her parents' understanding of Kaylee's clinical issues and how they may impact driving? Are they in favor of the plan to have their son teach her to drive? Does that demonstrate some denial about Kaylee's true abilities and deficits? What do we know about the brother and his abilities or understanding of Kaylee's needs? Teaching someone with ADHD to drive may take more than the usual skills. Of course, you can already see that we need more information to make a good decision, but that doesn't change the occupational therapist's obligation to make a recommendation to wait and warn of potential safety issues based on the information she already does know, and she has enough information to make an accurate and professional recommendation. Kaylee and her family could benefit from a firm recommendation by the occupational therapist to wait and reassess in a year or so. See at that time whether she is ready for driver training. The occupational therapist has an ethical obligation to make that recommendation based on objective data. Also consider if training is postponed for a year, who and what is the most appropriate and skillful training method and personnel. In addition to the occupational therapist, might Kaylee need more than a typical driving course? And might she benefit from working with someone who has more specialized skills? Consider potential referrals, and also think about alternate mobility methods if Kaylee is ultimately not deemed safe to drive. Finally, although there is a difference between ethical and legal obligations in many cases, in situations such as this one, from a legal perspective, it's important for practitioners to be aware of graduated driver licensing laws in states which may have a mandatory limit on non-family passengers in new drivers' cars and other restrictions. This ethics module was developed under cooperative agreement between National Highway Transportation Safety Administration, NHTSA, and AOTA. It will be available shortly on the AOTA website and can be shared freely. In addition, a CE on CD titled, quote, Duty to Warn, an Ethical Responsibility for All Practitioners, unquote, is available through the AOTA store on the website, www.aota.org, and provides additional information and resources on this topic. Thank you.